Welcome, everyone. What may be a boring seeming subject is really, really critical, and I hope to show you why as we go along today. Taking records, relatively easy. Taking quality records, much more difficult, much more precise. So let's jump right in. What are clinical orthodontic records? And there are some standards. There's some variations, but the reality is most of them involve three things. We're going to talk about clinical photos. We're going to talk about intraoral scans, and we're going to talk about radiographs. The primary focus is going to be on the photos because the other two are really going to be things that you get your information primarily from the scanner company or from the X-ray company. But let's jump in. What do clinical records do? Well, they allow you to show what the patient looks like when the patient isn't there. That is the main reason why we take them in a standardized way. That's the main reason why we take them at all, is so that when we sit down and maybe submit for aligners, or we want to go back and say, wait, did we get that right? There are certain things you can't do that you have to do clinically. What's their bite? Are they in CR? Those sorts of things. But the clinical records are really what we use when we're sitting down in treatment planning if we don't do it at the chair. The second thing they are is a baseline to compare to. So as you go along, when you're looking at pictures along the way, or you're looking at the patient along the way, you can always refer back to where you started. And you want to be able to tell exactly where you started in all the dimensions. It's a chance to show before and afters. And this is helpful, right? Before and afters, just for your own training. What did I start with? Where did I finish? How did I do? But it becomes a really big marketing issue. When you show before and afters, you show patients, potential patients, or patients and parents what you can do and what other people like them had happen. That's where really the rubber hits the road. So standardizing them makes all kinds of sense. Otherwise, what happens is the before and afters look so different that it's very difficult to put them up, or they're in such poor resolution that when you go to print them, they don't look good. And the fourth one is collaboration. And with all the electronics that we have, and in fact, OrthoFX has a collaboration platform that I work with. I'll show you some of the cases I'm working on that platform, where you don't necessarily have to be in the same room, same town to work out cases. If you have good records, you can share those, and you can do this from just about anywhere. As I said, clinical photos, radiographs, and the intraoral scan. And the intraoral scan is critical because often now you can order appliances, not just aligners, but other appliances from the intraoral scan. So what are they not? They're not headshots like on the left. They're not the shots that you'd use to promote your business. They're not selfies, and they're not glamour shots that you would do for, I don't know, for your high school graduation pictures. These are really clinical photos that are designed to show certain types of anatomy. What we sometimes get when we go to do treatment plan are photos like this. And this is a darling lady that I got a chance to work with after she had been in aligners for 5 years. And these were the original photos that were submitted. These were not the ones I took. But after 5 years and 5 refinements, she came to my office to see if she could get her back teeth together, to take care of some residual crowding, to make her smile better, all those sorts of things. That's not what we want. These are more what we want. Different ones. This is Elijah. Elijah is a friend of mine and a mentor, and he has a mastermind that I'm part of. These were the photos that were taken to submit for his Invisalign. And there are some problems. And as a result of this, you really can't tell that he's class 3 when he starts. All you see are the spaces based on the records. And when they closed the spaces, and they did a good job of it, closing spaces, what they did was they caused some other problems. So now he's wearing his front teeth down. He's got no posterior teeth touching. They've gone through 5 refinements because that's all they had. All they did was aligners. And so they went ahead and did the aligners, and oh, I still have a problem with the bite. Okay, let's do some more aligners. Doesn't mean it won't work. You just have to do it well. That's where the collaboration would come in. So these are the sorts of pictures you will want to see. These were the standards in my office when I took them. Three primaries of the head. One is the profile view. One is the front in repose, and the third one is the smiling. And we'll go through each of these in detail. We have occlusal photos, and then we have 5 intraorals, 2 occlusals, a right side, a left side, and then the straight on. We also took one with the mouth open. What affects the quality of your clinical photos? The first is the orientation. Okay, and foremost is the orientation, and that's basically the relationship between the camera and the patient. Everything else is immaterial. You can have the patient standing, sitting, whatever. If you get the orientation right, you're going to get it right most of the time. The second one is exposure, which is less of an issue now, but still an issue. It used to be with SLR cameras, you'd adjust the f-stop and so on. But what would happen is you would take them at different distances from the subject, and you'd get overexposure, underexposure, big differences in exposure just because of how far you're taking them away from each other. Filling the screen is important with the critical anatomy that you want to see. You don't want to take pictures from far away, as I showed you. When you go and you zoom in to the anatomy that you really care about, you don't want to see the background with a sink or a faucet. You want to have something that doesn't show anything. So all you can focus on is the anatomy. And you want to fill that screen with it, because then when you go to crop in, you don't lose the resolution. And you need that resolution. You need probably 200 to 300 dots per inch to have it look good on a screen like this. You probably need more like 600 if you're going to print it. And it really depends on how big you're going to print it. An 8.5 by 11, side by side, that's going to require 600 for sure, and maybe a little bit more to look good when you print it. So fill the screen with the anatomy that you care about. And then standardize how you take them. So when we standardized, and we had an SLR with a flash and an SD card, which is just a memory card, I don't think you need to do that anymore. Just get rid of those and use a cell phone. Okay, for most things, you can do that. If you're doing really high-level presentations, yeah, use an SLR and learn how to use it. And there are courses to do that. But a cell phone will do most of the focusing for you. It'll do most of the getting the colors right and getting the exposure right and adjusting the f-stops, all of the things that you have to do by hand with an SLR. You want to have a wall with a solid color. So it doesn't have to be white, but the closer to white you get, the better you are, because when you go to print it, it takes a lot more ink to use a blue wall, for example, or a blue background than a white black background. You're going to need to have cheek retractors. Many companies will send those to you when you take records. You need an intraoral mirror. I got to where I was only using the intraoral mirror for the occlusal shots. You can do them without, but then you can't look straight down on the teeth. So an intraoral mirror for occlusal shots works well. There are also intraoral mirrors for side shots, but not everybody uses those. We had a warmer for baby wipes in the office. And basically we'd keep the mirrors in there, turn it on every day, put paper towel between them so that they wouldn't scratch. But we'd keep them in there so when we went to use them, the mirrors wouldn't fog. Well, if a patient breathes on a cold mirror, it'll fog up. The alternative, it would be to have hot water running. Okay, and then you put the mirror under the hot water, get it warmed up, wipe it off, and take the photo. But in any case, you want the mirrors to be warm, otherwise they'll fog up, and you got to time your photo between breaths, which is not fun to do. And then a paper towel between them to prevent scratching. We put painter's tape on the floor where we wanted the patient to stand and where we stood, so that we always had the same distance for extraoral photos. You're going to want a stool, something for the patient to sit on that's adjustable, that you can move up and down, because you want to be at their level. You want to be eye to eye with them. So if you're short, you may want to stand on a stool. If they're short, you want them to stand on the stool. But in any case, what you really want to do is get your eyes and their eyes at the same level. We talked about the mirrors wrapped. We talked about the painter's tape on the floor. I mean, it doesn't have to be obtrusive, but you want something where you say, this is where you stand. Here, put your toes on this line or straddle this line. And then you want something on the back wall. Now, we had a slave flash, and that's basically a box with a flash inside. When we took pictures and the flash went off, then the slave flash would go off and light up the background. That's a good way to do it, but you don't necessarily need to have that kind of an expense. If they're not flush, if you don't have the patient too close to the wall, you can take it, so long as there's something shining on the wall, you can take a picture and not get a shadow. That's what you're really trying to do, is eliminate shadows. You could put just a light behind the patient and light up the back wall. But if the back wall is lit up by the light in the room, just have them stand a little ways off, 2.5 feet away from the wall, and you should not have a problem with shadows. So the right profile, let's talk about technique. Essentially, you want to come straight from the side, and you want to come, essentially, for this one, probably the most important single criteria is you want them at their normal head posture. There are certain head postures that speak to having an airway problem, and so you want to be able to see what their head posture is. And the way we would do that is we'd have them close their eyes and just bounce their head a little bit and then stop. And once they did that, then stay there. Okay, now open your eyes, close your teeth together, that sort of thing. And then you take the photo. In front of a solid wall, obviously, turn to the right. We had them straddle the line so that it was the right distance, the line on the floor that I was talking about. Make sure they're biting in their natural bites. Patients have a tendency to shift their jaw forward a little bit. Make sure that their hair is not blocking their ear. One of the landmarks is the internal auditory meatus, but you can see it from here, and you want to see it on your photos. That's a really important one for facial balance. You want to not have them wearing glasses. You don't want anything obtrusive on there. You want to see their anatomy. This isn't glamour. This is just what is their anatomy. You want to see all the way down to their clavicles, and there's reasons for that. You want to see the neckline. If we had seen that for Elijah, chances are we would have known he was class 3, and we might have changed our treatment plan. And then we talked about normal head posture. And if you don't do that, if you're at a different angle, or if you don't take it from a certain distance, and this is the same patient at different time points in my office, the same exact patient, and these are cropped. So imagine when I'm doing a presentation, I'm trying to show the progress of a patient. I have to go in and resize their head. You can see in the top left photo, well, all the top 3 photos, she is exposed more than the bottom 4. You can see that her head posture changes between the top 3 and the 4th one, but it's different on the 5th, and then it's back to the same on the 6th, and then the last one is still with the head up a little bit. Okay, so you want to standardize all of these things so that when you're comparing before and afters, you actually see before and afters and they look similar. We have all kinds of problems with hair covering the ears, or the glasses are left on, or we have them do some artificial head posture. You want them in their natural head posture. You don't want them overexposed or underexposed. That's where the distance comes. And you want to be at their height. The other thing is we can sometimes get pictures like this where they're rotated a little bit towards you. You should not see the other side, the eyelash on the other side. Okay? You want a true profile of the patient. Second photo is the frontal relaxed, right? Again, solid white wall, have them turn towards you with their toes on the line on the floor, patients biting in their natural bite. You don't want them biting hard. You don't want them strained. You want to just have them relaxed. Hair behind both ears so that you can see the symmetry, and then down to their clavicles. And again, the top 6 are the same patient at 6 different intervals. And obviously there's an exposure issue. There's a size issue. Some of them she's tilted a little bit to the right, and some of them she's straight up and down. The last one it was drawn from another case where there's a blue background, and you can see she is, her hair doesn't show. So you really can't see where her head stops. You can see the face, obviously, but not where the head stops, and it's out of focus, which means that they took it from a long way away, and then when they went to bring it in, it was out of focus. Okay, all the same criteria as the first one. Camera at the same height as the patient's face, eye to eye, heads rotated straight at you, those sorts of things. The third extraoral is frontal smiling. Okay, same exact position, right? They're standing there, they're looking straight at you. You want to be able to see smile. You want to be able to see the buccal corridors and the gingival display. Those are all critical to doing smile design in orthodontics. So have the front of the white wall, have them turn towards you. Same thing as we did for the other 2, well, for the last one, but you need to have a natural smile. And I would say you can tell if it's natural if they're laughing with their eyes, right? Because what happens is people don't know how to laugh on command. And so if you don't do it, if you don't see that in their eyes, then tell them a joke. You say, all right, go ahead and smile. And they give you some cheesy things. Say, oh my goodness, really? You call that a smile? And they will smile. Now they might smile and tilt their head, say, that's the smile I want. Let's put your head straight back up and down. Okay, now that smile. And they'll remember the joke and remember what they did. And then you get a natural smile. But that's critical. Otherwise, don't take the picture. This is a critical picture, is to see their smile arc. And again, pretty much this is where you want the camera to be. You want to fill the screen like this. You want to see from the top of the head down to the clavicles. And there's anatomy that makes a difference all the way along there. If you don't do that, so in fairness, this young lady had just had jaw surgery and had forgotten how to smile, okay, in the left photo. And so I said, all right, we need a smiling picture. That's what she gave me. I said, you know what? Let's have you look in the mirror and see how you smile, okay? So once we debanded, she was able to see again. It's like when I had my Achilles surgery. I had to learn how to walk again, okay? They had to learn how to smile again. You want a natural smile and see what you actually accomplished in your treatment plan, okay? So the right, not the left. We have all the same things, overexposure and underexposure and head rotated, but you know, you got that from the last set. When we go intraoral, the first one is looking at the patient, straight on and seeing what the teeth look like when they're biting down. Plain and simple, okay? They should be seated. Usually I had them in a dental chair. And there's probably the most important single thing to remember is back to when I said, it's the orientation of the camera to the patient. So if they're laying in a dental chair and their head is straight up and they're looking at the ceiling, you're going to have a hard time taking good pictures, because normally most people are right-handed. They'll stand on the patient's right side, but it's very difficult to get the camera far enough over and actually see the screen to take the picture. What you want to do is just tilt the patient ever so slightly toward you. Then you can get the orientation proper. Okay. Then when you look, you'll see about the same amount of teeth on the right as on the left. You'll see the midlines as a true midline. Here's where they really are. You'll be able to see overbite, overjet. You want the gingiva away from the teeth, away from the gums. And so when you have them use the lip stretchers, they put them in, most people will just pull them straight back. You can't do that. You have to have them in there, get a hold of the lips, pull them wide, and then pull them forward. That's what gets the lips off the gingiva. So make sure they're biting in their natural bite. Make sure that the horizontal plane is horizontal. The occlusal plane is horizontal. How do you do that? Well, the molars, if you look at the second molars and you draw a line up to the incisors, that should be pretty much flat across the screen. If it's a curve, you've got them looking down a little bit. And so you could make the case for this one's a little bit down, but it's pretty close to where you would want to be. Again, fill the frame with the teeth, and you want to see some of the gingiva, because when you crop it, you want to be able to see all of the teeth and a little bit extra. Okay. But if you don't get that right, all kinds of things happen. And the most common one is that the camera is not on the same plane as the occlusal plane. So you have to think of an imaginary occlusal plane and look at that upper right picture. Obviously, they are right-handed and they're taking it from the patient's right side. They are angled up toward the patient's teeth, and you can see more of the left side than the right side. It's pretty close, but you can see more on that upper right picture. If you look at the middle lower picture, you see way more of the right teeth than the left, and it's tilted. If you look at the one next to it, same patient, different time frame, different exposure, and it's angled the other way. On that one, you see more of the left than the right. And when you put those next to each other, your audience, when you're trying to explain, here's what we did, are distracted because they can't transpose that. They can't work that out in their head of what the difference in anatomy is. So when you're trying to teach something, it's very difficult to do. And honestly, this happens at the worst possible time. You might have the perfect teaching case that shows your work is so spectacular. You have an unbelievable restorative case or orthodontic case that you went from just jacked up to beautiful. When you go to get those photos is when you're going to look and say, oh my goodness, we forgot to take this one. Or, wow, this one is at such a weird angle. And you can't go back and take it. You're just sunk. You can't use that case, or you have to explain your photos so that the audience understands. And now you're detracting from your message. Okay. And the audience could be the audience of one. You want to have your teeth restored? Let me show you what we can do. That's what you want to be able to do. The final one is the intraoral, or the final second one is the intraoral with the front open. And really, this is the same as the last one, only with them open a little bit. And all you're looking for here are the incisal edges. What's going on with the uppers? What's going on with the lowers? What are the connectors? What are the line angles? That sort of thing. You look at the lowers, we didn't do what we call the Hollywood treatment on those, where we reshaped them to look like teeth, but we did do it on the uppers. And there's a whole science to that. Probably do another lecture on just that, okay? where the radius in the middle is a little less than the next radius, and so on, okay? There's a whole science to it, and the heights of contours of the gingiva. Bottom line is, this one is really to show the incisal edges and to show if there's a really large curve of Spey. If you get it right, it looks pretty good. But you know, in this case, we had one on the left that was at one time point. On the other right is what she did at a different time point, same patient. You can't compare those very well, right? You can't show before and after and say, here, look what happened. Nobody can see that unless you're able, you know, unless you do this for a living, and most patients don't. Okay. You also have all the same other problems with overexposure and underexposure and that sort of thing. But what you're looking for is standardization so you can compare before and after. When you go to the left, there's a whole bunch of things that can happen. What you really want is to kind of think of a plane that matches the buccal surfaces of the cuspid through the first molar. And you want to take your picture perpendicular to that plane. Okay, so the middle line down here. Oops. The middle line. Okay. And you want to take it so that the right side and the left side are on the same plane, and that plane is flat and through the middle of the picture. You want to see the first molars. And there's a technique to that. So what you want is the patient seated, looking straight ahead. So this is different than the last one. You don't want them tipped toward you necessarily. You want them normal position, but hold your head steady. And then you put the lip stretchers in. Now this is the left side. So the right side, I would have them hold. The left side, I would hold the camera in my right hand, and I'd hold the lip retractor in my left hand. I would go ahead and say, all right, bite together. I'd get it framed. I'd hold the button down halfway so it starts to focus. And then at the last minute, I say, just leave your right one in there gently. It has to stay in, but it doesn't have to be, you don't have to pull on it. And then I'd pull on the left one till I got the first molar. Okay, and then take the picture. And if you do that, you'll see everything you want to see. You want to see the overbite, you can't really see the overbite, but you can get an idea of the overbite, the overjet, the angulation of the incisors, whether it's class 1, class 2, class 3. You see a ton of information if you do it right. If you don't do it right, you don't see a ton of information. That upper picture is Elijah's teeth. You can't tell if it's class 3 because they didn't take it properly. Now, they took them the same. You'll see in the next error slide, the same one. But no, you can't see the classification. So he's 5 years in and he's worn his teeth down. You can see in this picture that the upper lateral is small, but that wasn't accounted for in the treatment plan. You can also see on that lower right, well, the lower three are the same patient, right? So the lower left, he's a little bit class 2, but we can't tell how much because we're coming from the front. The other thing we can't tell is because we're coming down at the patient, we've got a distorted view. And so if you look at the angle between the occlusal plane, if you look where the occlusal plane is, we're nowhere near that. The frontal one is a little better, but the left side on the patient, same problem. And that's one that you'd love to be able to show after, because you know with all the spaces, you're going to take that overjet and make it significantly less just by closing the spaces. And then if you do a little bit of class 2 correction, it's going to be an amazing finish. But you're going to have these as your initials, and then your finals, doesn't matter how good they are, they're going to look funky compared to these. Again, you can overexpose, underexpose, all the same sorts of things. The main one, though, is orientation. On all the intraorals, it's orientation. Right buccal, really, that's the same as the left buccal. The technique is the same. The thing that you're trying to see are all the same. The problem is most of the photos we see coming from outside, not from an office, although we get them from the office as well, are with this arrow on the lower right, the one that comes from in front. okay? Like on the lower right of those 6 photos, that's Elijah's other side. Same problem, can't see the class. Now, if you look at the upper 3 photos, that's again the same patient at 3 different time frames. Notice how each time it's different on how many teeth are exposed. Okay, that's pure and simple technique. If you always get the first half of the first molar, then you're always going to have the upper right hand kind of thing, right? If you look at the lower left picture, we're looking from above, and we're not looking directly perpendicular to the facial surfaces of the posterior teeth. We can't tell class, and it's out of focus. So, about everything you could do wrong, we did wrong. Now we know it's all, it's spaced and all that sort of stuff, but the reality is that doesn't teach us what we need to know. Same thing on the middle one on the bottom, because it's out of focus, and you've got, you can't even see the gingiva on the bottom. What if he's got a dehiscence on that first bicuspid? You'd like to know that. You'd like to document that at the beginning. So you want to be able to see the teeth and the gingiva right next to the teeth. I've got a couple of questions up here that I'm going to try and answer now, and then I'll come back. We take a picture with a mirror for the occlusal shot. Do we need to reverse it horizontally so tooth number 3 is not seen as tooth number 14? The answer is absolutely. Yeah, and most softwares, when you put them in, will automatically compensate for that. Okay, or you can do it behind the scenes. I know that's true of orthodontic software. I assume that's true of dental software, that there's some controls behind the scenes when you put them into an array that you can say, whenever I put this one in, reverse it. Do I take the photos or an assistant? One person takes them, right? I designate an assistant to take them. I rarely took photos unless I knew it was a teaching case and I knew they had to be pristine, in which case I'd take them. I spend a lot of time and energy teaching my assistants, and they were really, really good, but not perfect. Okay, if it really, really mattered, I would do it myself. So if you've got, and the problem is knowing ahead of time which case is going to be the perfect teaching case. You don't know that. Okay, so I know it's going to be difficult, but really you can take the intraoral and extraoral photos. 5 minutes, 3 minutes. Doesn't take long, especially after you've done it a few times. You know exactly what you're looking for. You have it in a sequence. My sequence was I would do the extraorals first. I'd have them stand. I'd do, position them for the profile shot. Okay, put your teeth together. First, I do the head orientation. Then I say, put your teeth together. Okay, hold still. And then I take the photo. All right, turn toward me, put your toes on the line. They look down, put their toes on the line. Look toward me. Oh, your head is tilted. Can you tilt it to normal? They do that. Snap the picture. Okay. Now I need a natural smile. Can you give me a good smile? And they do it. And I say, oh my goodness, really? That's your best smile? We're going to have to send you to class on that one. And, and get the natural smile. Take that one. On intraorals, what I would do is I would first take the frontal one. And again, put both lip stretchers in, teach them how to hold it out. They would hold them forward and out, and then say, okay. And I wouldn't have them bite down till the last second. I'd get it oriented. I'd get it focused halfway, press down the button halfway. It'll start to focus. Say, all right. And on that one, you want to focus on the bicuspids or the canines. That's where you want to focus. So that you get depth of field. But get them oriented, then say, okay, bite down in your natural bite, double check that it's natural, and snap the photo. Then I would do the side ones the way I just described. And then I would do the occlusals, because the occlusals are the most uncomfortable for them. On an occlusal photo, what you do is you put a mirror in and you angle the mirror such that it's basically what you're doing is you're taking the photo, and I don't have a great photo of it. I apologize for that. You put the mirror in, and then you want to bisect that angle with the camera so that it appears that you're looking straight down on the teeth. You can see here, we're looking straight down on the teeth, okay? And you can see the second molars in the mirror. That's a technique issue. You can see the mid-palatal raphe is in the middle. That's a technique issue. Ideally, you wouldn't see the lip retractors. These are metal lip retractors, and you can see them. You wouldn't see those in the picture, but we see all of the dental anatomy and then some. You can see behind the teeth, there's some gingiva. You can see the cheeks on the side. The cheeks are out of the way. I mean, this is a really, really good occlusal photo. So what do we do? How do we do that? Have the patient seated in the dental chair. So I've done all those other ones. I'm coming on doing these. We're going to put both the lip stretchers in, show them how to hold them forward a little bit, right? Then I take the mirror, I've got it warmed up, I take it out, either dry it if I warmed it up in the sink, or just pull it out of the warmer. I would then place the mirror in and against the upper second molars. And I would then take my camera, get the right angle. Then I would focus it, press halfway down and focus. And at the last second, I'd say, I need you to open real wide. They would. I would drop the mirror off of the second molars and snap the photo right now. Okay? That's how you get them this way. So again, put the mirror on the teeth so it's comfortable. Remember, when you push down on it, you're going to be pushing on the tongue, and then you're going to have a gag reflex, and it's going to be uncomfortable. You want that minimal time. So put it on the teeth, get everything ready to go, get the right orientation, make sure they're turned towards you. Otherwise, what you're doing, you're going to get at an angle, and then drop the mirror, take the picture. All kinds of variations on a theme. On the upper left picture, you can't see the second molars, especially not the upper left one. Well, patient's upper right, which is upper left in the mirror, right? Also, the mirror is tilted right to left. It's not flat. It doesn't match the occlusal plane, right? And when you take it off, you should match the occlusal plane. Bring it straight down on both sides. So the AP angle is not going to match the occlusal plane, but you're basically going with the lower teeth, and then you're shining your camera at half of that. The lower left is more exposed than the lower right. And you can't see the upper incisors in either one of them, right? The lip stretchers in the lower left are in the picture blocking anatomy. They didn't pull sideways. They just pulled backwards. Okay. Now, are they horrible? Well, no, they're not horrible. But is this one you're going to put on your wall, showing before and after, where you see the front teeth are crooked, and then on the last part, you don't see the front teeth at all? And people are going to say, oh, he didn't show the front teeth because you never got those straight. That's not what you want. The reason the resolutions are different is because of settings on the camera or distance from the subject. When the flash goes off, it lights up the subject. The closer the flash is, the more it will light up the subject. So the distance makes a huge difference in an SLR camera. It still makes a difference with a cell phone. Okay? So overexposure, underexposure, bad angles, we got the whole thing. Lower, very, very similar. You notice we can see all the anatomy behind the teeth. We can see, we're looking straight down on the teeth. The tongue is down out of the way. The cheeks aren't covering the teeth, okay? And you do them the exact same way. You sit down, you get them oriented, you put the mirror in, but you hold it up against the upper teeth, and there you get it as comfortable as you can, get it focused, get it ready, then say, I want you to open real wide, do your final adjustment really quickly, and snap the photo right now, okay? You don't want them in that position for a long time. It's awkward for them, and then it becomes awkward for you. And again, variations on the theme. You can see on the upper left, they've got the mirror skewed to the patient's left side. I have to turn them upside down and backwards to get there, but yeah, left side. On the lower middle one, the angle of the mirror is tilted from right to left. The lower one, you can't see the incisors, and the tongue is up over some of the teeth. Lower right one was one that they took from a distance away. They didn't get all the teeth. They didn't get the second molars. They didn't get the lingual cusp because the tongue is up, and they took it far enough away that when they zoomed in, it was out of focus. Okay. Now we can tell there's a lot of crowding, but that's all we can tell. We want to tell more than that. Now, you can take them the old-fashioned way, and you can have software in your office that puts them in certain order and all that sort of stuff. And that's how we always did it. I never ever used an app, but now several of the aligner companies have an app for you to submit photos. And so I'm going to show you a really brief video that it has first some information that well, I'll play the video and talk over it. So you put in the username and password to sign in, then you decide where you are, which office, make up a new patient, right? You put in their ID information, you can scan in their insurance code and all that sort of stuff. Put all of that in there. You're the treating doctor. You pick the material. Some companies have more than one material. OrthoFX, for example, has more than one material that you can choose. And then when you get to the photos, it gives you an orientation. It says, put the patient in and make them look like this. Okay, and it does that for every one of them. It didn't show you each of them. And then you just send them in and boom, they go. You can see in real time. That's how long it takes once you've taken the photos. That's how long it takes to send. And they go right in. Now, I would caution you a little bit. Those will get you the case submitted. What they won't necessarily do is they won't necessarily give you a great before and after opportunity. So I'm still of the mind that you should take some yourself so that you can show your work. There's nothing better than showing what you can do all around your office. So we talked about if the patient's too tall, hey, adjust to them. You stand on a stool or a footstool or whatever, have them sit down, do something to make it the same height. If you have no wiper warmer available, then run them under hot water, right? Make sure that you don't scratch these. They're really expensive, or they're relatively expensive, certainly in an orthodontic office, and I would think in most GP offices where they do a lot of cases, they could get scratched because you've got 7 or 8 sets in there, and if you just throw them in, they're mirrors, they'll scratch. So we've talked about photos quite a bit, and really that's the one that's the hardest to do and the most technique sensitive. The second piece is the intraoral scan, right? This is critical for liner treatment, but it's also critical for other treatments. And I contend that if you're going to do orthodontic treatment, if you're just doing aligners, you're severely limited in doing great treatment because it's difficult to extrude incisors, for example. That you should do some other way. It's almost impossible to get expansion unless you're doing it at 6 or 7 years old. And even then, there's more efficient ways to do them. And then efficiency in other ways. So you want to get a great intraoral scan. You can send the scan for appliances now, whereas you used to have to fit bands, take an impression, send it. You can send a scan and get appliances back that are custom made for that patient. So some companies require you to use their own scanner, whatever scanner they sell, that's the one you have to use. Others are scanner agnostic. Whatever you can get an STL file, send it in. Okay. My feeling is I don't want to be beholden to one company who's got me hostage with their scanner. The technique will vary, maybe some a little bit by manufacturer, but really it's a the wand goes over the teeth buccal lingually and back. Where people really make mistakes is primarily in the anterior. What happens is they go across the buccal, and then they go across the lingual, and then they say, well, I have to do the occlusals, right? So on the posterior teeth, they do the occlusals. And essentially what the computer is doing is it's reading the information coming back from the scanner and saying, okay, I know where we are in the mouth. This is what that is. And then they're adding the occlusal onto that to make it, and they can marry the buccal and lingual. What you really want to do is go lingual to buccal and then move forward and then go buccal to lingual and go back, and so that you don't get voids as you go along. And it's most important in the front, because if you do it in the front, what happens is the computer can't resolve that. And so you get some funky thing in the front and they can't use it. So the actual technique, there are videos out and the manufacturer will teach you and so on and so forth, but that's the basics, okay? The second most important thing is double check the scan before you submit it. There are some of these that you're gonna see, you're gonna think, how in the world was that missed? Someone either didn't know what they were looking for, or plain and simple just didn't look. So what should a good scan look like? Here's just one example. I moved it around. That's what the arrow is doing. You can see, can see the gingiva all the way around, even distal to the second molars. You see zero voids. There's no voids between the teeth. There's no voids on the teeth. Everything is a solid piece. And for a liner treatment, this is really good scan. Okay. My problem is, and I want to, oops, I can't stop it. My problem is when you get to the palate, they didn't do the palate. On the top, I would do the palate. And the reason is, if I do decide to use an expander, and this one looks narrow to me, then I can just send in the scan to get I don't have to do anything more. I can send it in a week later, whatever. But with a scan, you can send it in like post haste. It goes right now to the company, and they start fabricating the expander for you. And then all you have to do is deliver. There's no more separators, no more any of that stuff. When you don't go buccal to lingual and forward to back, this is what you get. Okay, you get a double image. Why? Because the computer can't reconcile those two images. Same thing on the left, it's normal. On the right, it's not. You can get elongation. We used to get this a lot with impressions. If you take an impression to send in, which I actually don't recommend, the scan is so much easier. I mean, back in the day, we would take an impression, but it would take us 5 or 6 impressions to get one that worked. With a scanner, if it's not 100% right, you can retake it in 3 minutes and it doesn't gag them. But you can also just go in and just fix certain spots. You run the wand over, say, fix it, and what happens is it analyzes that anatomy and says, oh, I know where I am. And then you add the piece that's missing and it's all fixed, okay? They're also a lot more accurate than impressions. Those thin incisal edges that you see on the left shouldn't happen. That's not normal anatomy. I mean, you could look at that and then look in the mouth and say, was it a good scan? But then you have to know anatomy. Just make sure that you're rolling from buccal to lingual so that it can see the incisal edges of the upper anteriors and lower anteriors. And then you'll get normal, like on the right. This is just somebody wasn't paying attention, okay? You got missing anatomy on the teeth, and the whole buccal surface is missing, or half the buccal surface of the first molar, and then pretty much the entire second molar is missing. So the question is, do you want the aligners to cover the second molars? Well, yeah, you do, because if they don't, they're going to hyper erupt as you're wearing them. It's critical to get all of the anatomy. Same sort of thing. Okay, where they're missing anatomy, missing teeth, should never happen. And it wouldn't happen if they're looking at the end saying, do I have a good scan? And if I don't, go back and fix it. Just variations on a theme, that upper right, or I'm sorry, lower right canine completely missing. These are deviations that, like the middle upper picture, it looks like they have two teeth there. Like the roots got scanned and then the thing moved over. In an impression, I would say what they did was they got halfway through and then they moved the impression, right? The patient moved or they moved. And so they got an impression that's solid on the lower half of the tooth and then a separate on the upper half of the tooth. But these are all scan errors that don't have to happen. And this is what you don't want, right? Dear doctor, please take a look at the attached screenshots. Unfortunately, we're unable to use the scan due to a problem we call double impression. The scanner does not properly merge. It can't figure out what things go together. Can't merge the data between the buccal and lingual surfaces. Since the file cannot be used for modeling, rescan the patient, capturing a full scan of both arches and bite. You tell me, how is that a good thing for anybody? You've got to take time out of your day. You've got to have either you or an assistant to retake the scan. You've got to inconvenience the patient, which is a bigger deal than the 15 minutes they're in your office. They got to, I mean, if it's a kid, it's an hour and a half to 3 hour process for them to go get the kid out of school, drag them down to the office, wait, get in, do the procedure, go to McDonald's, get the food, ride to the school, go back to work. I mean, I've done the math. It's a big deal. You don't want to do that. When all you have to do is look and say, oh my goodness, it's not right. Let's do it better. So what are clinical records? They're a representation of the patient when they're not present, a baseline to compare to, a chance to show before and afters, and an opportunity for collaborating with other professionals. So we're back down to Elijah. There's where he started, right? And you can't see these class 3. And here he is 5 years and 4 refinements later, right? Spaces are closed. They did a great job of doing that, but he's a hygienist. And he knows this isn't right. Look at the upper left photo, before and after. Before and after. And tell me, how are you? I mean, I'm distracted by that. Look at the central photo on the top. They got the computer screen behind him. White wall, something innocuous that you're not going to pay attention to. If you do it right, then your before and afters look the same. So this isn't an aligner case, but it gives you an idea of what can be when you're showing your work. Before, after. Before, after. You see how the gingiva look the same? You see how the teeth look the same? The exposures are the same? Yes, the orientation could have been a little bit better on the lower one, but you can actually see all the posterior teeth. You just can't, you see more of them on the right than the left. I would be happy with these if we got these. It's when we get stuff that doesn't look like that, that makes me crazy. And honestly, if you're going to do good work, you want to have that shown up all over your office so that when people come in, they look and they say, oh, you did that? Oh, I'd be interested in having that done. What would it take? And then you can start a conversation. All right, any questions? You use a neutral gray tab to color adjust on the collar and then crop off. How do you get the colors more even? With a cell phone, I would say distance and ambient light are the two biggest things. So ambient light is how much light is actually hitting the subject from other sources, say the light up above. You have to have some. You can't take a picture in the dark because the camera itself can't resolve two different images next to each other. Basically, they see a tooth and a tooth, and there's a difference in between them, and they say that's where it ends. That's where I'm going to focus on because there's a line there. If you don't have a line, it can't autofocus. So you want to pick a distance, and you're probably looking at about a foot away. And what I did when I was using an SLR is I did all the different f-stops, all the different ones and all the different distances, and found out which one was best, tied a string to the barrel of the camera at the distance, and then when they took the picture, they'd have to hold the string near the teeth and say, okay, this is the right distance. Okay, because it's really the distance when it's a standard camera. With a cell phone, I don't think it's as critical. Which aligner companies are easier for beginners to learn? Record taking, treatment planning, and perhaps less equipment requirements. Thank you. So I'm not in a position where I can promote. This is a CE course, so I can't promote one particular company. Let me state that my bias is that we ought to use aligners to straighten teeth. In those cases where we've done a diagnosis and treatment plan that says this is a good choice. There are things that aligners do well. That the lecture I gave on the 11th, which I think they have up on their website, is talks a little bit more about that. So I think you do a diagnosis first, and there are a lot of ones that can be done with aligners only. The biggest ones aren't necessarily the most user-friendly ones. I personally like OrthoFX because of the collaboration. I no longer have an office. I provide treatment through other people's offices. And so, like Elijah's case, his general dentist is doing it, and I'm running the show. I'm consulting technically and saying, I think we should do this, I think we should do that, but they're delivering it in office. I would also look at the differences in materials. There are options for different materials in some companies, whereas in other companies, it's one material. The other factor would be how far, where is the aligner trimmed? Some of them scallop each tooth. Some of them go below the gingiva 1 millimeter. Some give you options. You can go 2 millimeters, you can go 1 millimeter, you can go scalloped. And there's an advantage to different ones at different stages of treatment. But those are things I wouldn't necessarily do on your own. Those are things that you would have somebody collaborate with you and say, all right, let's set this up and do it this way and that way. It probably seems like an extra cost, but it's an investment, because then you should have less, if you have the right person, you should have less adjustments, less refinements, and fewer appointments. What retractors are effective in retracting for occlusal photographs? Do I like the metal ones versus the clear ones? You know what? For the most part, it doesn't matter. It doesn't matter the material at all. But I liked wider ones for the occlusals. The wider top to bottom. And the wider ones, if you do them for, like if you do them when they're biting together, it can get uncomfortable. So I'd have narrower ones for that. And if you're doing occlusals, so long as they hold the lips off the teeth, you're good. Wider's better. I didn't buy two separate sets. I found one in the middle and just used them differently. So it's the technique that you use them is way, way more important than where you get them or whether the metal or plastic or the size or shape. By far, the most important thing is how do you use them? So things we talked about today are really way more important than whose do you buy, okay? The mirrors, I don't know that I'd go with the most expensive ones, because any dental mirror will do the trick. It's just the more expensive you get, you might get a little bit of improvement in optics, but you're probably going to get less chances of scratching them. And so long as you're careful with your technique, that shouldn't be an issue. These are great questions. Good job, guys.